Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Pleased to have with me today, as usual, my co-host, Dr. Daniel Lenihan. Dan is calling in this morning from the mobile office. Welcome, Dan.
Thank you so much, Steve. Appreciate it.
And our other co-host, Arjun Ghosh, got called into clinic, so he's not with us today, but we are glad to welcome today a friend and colleague, Dr. Sarju Ganatra, who is a cardiologist in the Boston area. And Sarju, we really appreciate you being with us, so thanks for joining us today.
Glad to be here. Thank you so much for having me, Steve.
Maybe before we jump into our topic, we're going to be discussing an article that you were the senior author on related to SGLT2 inhibitors. But before we go there, tell us a little bit about your background, your experience, how you got interested in cardio-oncology.
Oh, well, that's a long story. But I'll keep it brief. Before I started my residency, Steve, I came to Boston, was working in Dana-Farber in research, and was very much interested in doing oncology and committed to it. When I started my residency, I realized that outpatient hematology patients are very different from inpatient oncology, and was always fascinated with the physiology of cardiovascular system and like the procedures. So decided to pursue cardiology instead of oncology in the residency. And when I was a chief resident, I saw this conference at MD Anderson Center. I think it was their first or second conference. And I'm like, wow, I could combine my both interests, cardiology and oncology, by jumping into this field. And the rest is history, thanks to the mentorship from Dan and, many other pioneers in this field. Glad to be here, a small part of this growing community, and happy to be here today for this podcast as well.
Thanks for sharing that. That's helpful context. And the article that we wanted to discuss today, the title is SGLT2 inhibitor use and risk of clinical events in patients with CTRCD. Before we talk in detail about the article, could you just sort of set the stage for us? How did this come about? Maybe explain a little bit for our non-oncology audience. What are SGLT2 inhibitors? What's their mechanism of action? Just give us a little context for this study.
Absolutely. So SGLT2 inhibitors, as we know, they are not new drug. They've been around for last decade or so. I think they were first approved in 2013, I believe, for diabetes. So they are the, originally used and invented in patients with diabetes. Now, at that time, there was this complex situation with some of the other diabetes drug causing cardiovascular harm. And in that context, actually, FDA mandated that any diabetes drug has to have cardiovascular safety as outcome, as a safety outcome, not necessarily as efficacy outcome. So it was kind of, the arms were twisted for all these diabetes drug sponsor to have that included, which was fantastic, because what we are seeing today, for SGLT2 inhibitor is as a result of that they saw not a safety concern, but actually a lot of benefits. And since then, it's been the core part of the guideline-directed medical therapy, initially for heart failure with reduced ejection fraction, even in people without type 2 diabetes, then in the mid-range EF, and then in heart failure with preserved ejection fraction. So, for HFpEF, or as we call, SGLT2 inhibitors are the only drug which are effective after, blood pressure control, unlike HFrEF, where there are many options. So it was a truly game changer in that context. And now they are widely used for people with both ischemic and various forms of non-ischemic cardiomyopathy and heart failure.
Yeah, Sarju, that's a great summary. Thank you for doing that. I would say that, it's really kind of a surprise, in my view, the whole efficacy of SGLT2 inhibitors, specifically in heart failure, because, here you have a generally quite sick population who are on multiple medicines, and then you're adding another one. And, for the most part, anytime you do that, it's really hard to show a benefit, because, there may be a modest beneficial effect of whatever the drug is that you're testing. And, but in order to see that in a clinical trial, there really has to be a substantial benefit. It can't just be modest. And I mean, I can give you, I can certainly, you are aware of these, but certainly there are many, many drugs that conceptually seemed like a good idea that were looked at in the heart failure population. And really, if there was a modest effect, it was, hard to detect. Or in many other situations, there was actually a harmful effect. So then when you have this class of drugs with such a profound beneficial effect, to me, it's really astonishing. I don't know what you think about that.
Yeah, no, couldn't agree more. I think it's very fascinating that, it shows this degree of, large relative risk reduction in all the clinical trials in these cardiovascular sick patients as an incremental benefit on top of 3 layers of drugs, which were already, solid pillars of, heart failure treatment with ACE inhibitor, ARB, beta blockers, and aldosterone antagonists. And so, this benefit of SGLT2 is truly incremental because all the trials had people on these 3 drugs already, and having seen benefit of that as a 4th drug is really difficult thing, and we have failed time and again. So glad to see the one more addition of drug in for this relatively sick population.
Yeah, no, and so then applying that to cardio-oncology is really easy. I think the concept, certainly in my view, of cardio-oncology is that can we prevent heart failure? Can we either minimize its impact or prevent it altogether? And, that's a different focus than in traditional advanced heart failure, where most of those patients have very severe heart failure, and you're just trying to manage the problem, and maybe you'll go to more advanced therapies. But in the cardio-oncology space, it's quite common that their ejection fraction may be closer to normal or normal altogether, and then you're really trying to prevent the development of heart failure so that it doesn't impair their cancer treatment. So this is a very important concept. And then, so tell me about how you found the patient database for which you did this study. Where did that come from?
Yeah, so we basically use EHR based data aggregated by TriNetX from various medical centers across the country and some outside of USA as well. It's a large database of, I believe, more than 100 million patients. And out of that, we had a luxury of accessing, relatively large number of patients with CTRCD as well. And that truly was helpful because, what we were trying to see was that patients with type 2 diabetes and those who have cancer therapy related cardiac dysfunction, is this drug SGLT2 inhibitor as effective as it has been shown in other forms of ischemic and non-ischemic cardiomyopathy? Now, the pivotal clinical trial, the landmark clinical trials, what we often refers to, most of them had excluded these patients, patients with even cancer, let alone patients with cancer therapy related cardiac dysfunction. And that's what I think this knowledge gap usually comes from in cardio-oncology world, is that in cardiac trial, patients with cancer are excluded. In cancer trial, patients with cardiac issues are excluded. And so we are somewhere in between. And that was our small attempt to study this patient population who arguably is equally, if not more, vulnerable. And as a single center studies, it's really hard to do because that, no one center has that many patients. So we were lucky to, have access to this database and found relatively large number of patients, I believe around 650 or so, who were on SGLT2 and 6,000 plus patients not on SGLT2 with CTRCD. And we compared the two groups after doing, appropriate matching at baseline, and compare their outcomes for 1 year, that what happens once these people are on either 3 drugs, which is, as we all know, ACE, ARB, or ARNI, beta blockers, and spironolactone or other forms of aldosterone antagonist, or on 4 drugs with SGLT2. So it's remarkable that, all patients, this close to 7,000 patients were on 3 GDMT drugs, and one cohort was on additional SGLT2. So very similar to like the clinical trials were done. And we demonstrate a remarkable benefit in improvement in various cardiovascular outcomes, from heart failure exacerbation to hospitalization, which are very common for these patients, and very important solid endpoints, as we call, all-cause mortality, to other softer endpoints like atrial fibrillation, flutter, acute kidney injury, and renal replacement therapy, and so forth.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, so I think that this obviously is not a prospective randomized study, which would be super difficult to do. There's like no way that I can see of that you could actually do it, because in all of the heart failure-based SGLT2 studies, they of course exclude patients with cancer. So there's no way in a prospective randomized study in patients with cancer being treated for cancer are you gonna look for cardiovascular endpoints. That's just
Right.
it's just a combination of comorbidities that will never be prospectively studied, or if it is, it'll be a small study. So
Right.
I think that's why looking at these big databases can be very informative. It's not our strongest evidence, but it's certainly evidence nonetheless.
Yeah, as you said, prospective study would be really good, but really difficult in the real world context for these patients. And I think that's why we thought that while this is not the level 1 evidence we are generating, I think it's important as a stepping stone, at least on the way to be there.
So one other concept that seems very prominent to me anyway is, and I have to admit that for the last 10 or 15 years, I've really not wanted to focus on any sort of diabetes management.
Yeah.
I was like, that's just one complex condition that I don't think I can take on personally. So, I would always defer any decisions about diabetes medicine to either the primary care doctor or an endocrinologist. And usually it was an endocrinologist.
Yeah.
But with the whole SGLT2 inhibitors, you know, I am very compelled to prescribe them. And so I would prescribe them very often, and certainly in patients with heart failure. But based on this study, I would also feel very good about prescribing them in patients with cancer who are being treated with potentially cardiotoxic therapy. So you're sort of stepping out of, you know, the general comfort zone, and you're entering into the diabetes world.
Right.
How do you explain that to a patient?
Yeah, no, I think that's a very good summary of what we all have been doing for a number of years, differing, this metabolic disorder, diabetes, and others, their management to someone else. But I think with the time, we have come to realize more and more that cardiovascular disease, cancer, and metabolic disorders such as diabetes, they are not different. They may manifest differently on the surface, but at the molecular level, they are tightly connected with the shared pathways and mechanisms. And we know now from large epidemiological studies as well that patients with diabetes more likely to have cardiovascular disease and cancer. Similarly, other way around, patients with cardiovascular disease to have cancer, another way around, cancer more likely to have cardiovascular disease and diabetes. So you can see how tightly connected. And as a cardio-oncologist, our unique role is to try to address all of them. And I think that's where, as you described, that the role of SGLT2 inhibitor and our comfort in prescribing them has increased, and if not, has to increase. But this phenomenon is not limited just to SGLT2 inhibitor. As you know, GLP-1 recently have shown great benefit in people with obesity, and diabetes, and without diabetes, and HFpEF. And again, the cancer is excluded from all this landmark trial, but we do know that people with obesity are at risk for many different cancers as well, and in general with metabolic disorder. So I think we'll have to get used to and be comfortable with managing people's metabolic risk factors, because they are truly cardiovascular and cancer risk factors. And also they are prognosticator once they have cardiovascular or cancer.
Yeah, no, I absolutely, completely agree with what you just said. And the thing is that where years ago I would have deferred any decision making about diabetes to others, I would have focused on, hypertension or heart failure or whatever. At this point, I don't defer. There's no deferring. I would prescribe these medicines at every opportunity.
Yeah. And
then, as you just said, the GLP-1 medications, we're going to have to get our heads around that too, especially if they're shown to be beneficial from a cardiovascular point of view. We're really going to have to get our head around that. And so I think this is the future, and we're going to have to really embrace it. And the issue is that, in practice, prescribing these medicines is a lot more difficult than you would think.
True.
Here you have, it's kind of like when Entresto came out and was beneficial in systolic heart failure, a very important study, the Paradigm trial. For quite some time, it was really difficult to get people on that medicine just because it was so expensive. It wasn't available. And, so we had to make all kinds of adjustments in what we would want to do.
Yeah.
And so I think the SGLT2 inhibitors are just like that, because if you have a person that doesn't have very good pharmacy coverage, you know, an SGLT2 inhibitor is going to be $400 or $500 a month in the U.S.
True.
And so, how do we address that as a medical community, or how do you personally address that?
Yeah. No, I think those are all great points. I was just reading one article yesterday. I forgot the journal, was written by Deepak Bhatt and someone else, that, all the wonderful medications work greatly, only work in patient if they can take it, right? And so that's the science versus accessibility issue. And I would, take a step back from the safety standpoint, though, that SGLT2 inhibitors are relatively very safe as compared to many other, GDMT we are prescribing to this cancer therapy related cardiac dysfunction patient, or in general, heart failure patients. The risk of hypotension or hyperkalemia or renal failure or fatigue and other side effects, right, which we see with the other GDMT, is far less with SGLT2 inhibitor. And the benefit is, arguably greater, because it's shown the incremental benefit on all top of these three medications. So I think that's kind of the comfort zone a little bit more with the favoring SGLT2 inhibitor as compared to Entresto and other medications, which we had some initial difficulty. But I think the financial toxicity to patients afflicted with the dual diagnosis of cancer and cardiovascular disease is enormous as it is. And adding another class of expensive drug is really difficult. I've seen few different initiatives recently, I think under the Inflation Reduction Act and the drug pricing and cap being around $2,000, $2,500, somewhere there for at least Medicare patient. And I think that might be helpful, that at least out-of-pocket costs might be limited. Again, as a society, we are going to pay for it. So I think it's a larger question that how do we fund that? I saw recent at least application approval from Florida to FDA for importing drug from elsewhere. And, I don't know anything about it. I am not a technical expert on that, but I think we are starting to look for the venues to find cost-effective medications. And I think that will hopefully push the drug makers here as well to realize that, if we don't get it, access to it here, then we'll have to look for other avenues, and we'll hopefully push them in the right direction, so that all patients can access it freely.
That's completely true. And so just to follow on what you're talking about, I would say as a group or as a society, we have to find ways to make those types of medications available to the widest population because of their profound benefit. And in the case of, like, for example, 10 or 15 years ago, when carvedilol went to generic, and it's basically a $4 script in the U.S., I mean, to me, that was the greatest day in the history of heart failure, as far as I'm concerned, because you had this medication that was affordable. And so we need to have that same emphasis for SGLT2 inhibitors, in my opinion. So I think that this is a practical issue that we have to struggle with. But I think demonstrating that these medicines are really great in the cardio-oncology space, to me, is really important. And I applaud you for this study, because I think it takes us one step further in showing the real importance of those.
Well, no, thank you so much. And, I would like to applaud you and everyone else on the paper. You are one of the, senior co-authors then, as usual, with a lot of things we do together. So thank you for your guidance and being a part of it. And more to come, I would say. This is just the beginning. With this study, we are showing the benefit of this drug in the treatment of CTRCD. I think now the next step we are going to take is, does this drug help preventing CTRCD altogether, or, to what degree And not just this drug, but GLP and furthermore. So I think we need to expand this field of cardio-onco-metabolics as a part of cardio-oncology under the umbrella of ICOS and other members in the group. So thank you.
Well, and I think it really goes back to a message that we've been trying to, hammer home in everybody's, mindset is that, baseline risk stratification for any person that's undergoing cancer treatment is a critical step. So that baseline risk stratification, of course, includes, measuring lipids. It probably includes measuring hemoglobin A1C and, also NT-proBNP as a marker of subclinical heart failure. So these are all critical steps in terms of truly assessing the cardiovascular risk that a patient has when they're about to begin, very arduous cancer treatment. So this type of study, the one that you did, is really emphasizing this point again, is that we need to go there, we need to look, and we need to do our best to manage these conditions. So really, really fantastic study. And then the other thing I would also say is, Steve, in your introduction, you introduced Sarju and all that. You said, and he gave a little account of what or how he got interested in cardio-oncology. But I think you should add a little bit more on that introduction, which Sarju is always very modest. But I would say he's one of our rising stars and the younger leaders of cardio-oncology. And so we really look for him to help lead us into the next 5 or 10 years. So thank you, Sarju, for all what you're doing.
Well, thank you so much for your kind words. I won't go that far, but I'll take it with sincere thank you to you and Steve both and everyone else part of this journey. Thank you.
Sarju, thanks so much for taking the time today, and especially for your work on behalf of the community. I just echo what Dan said. We really appreciate all your contributions, and we'll look forward to speaking with you again soon.
Sounds great. Thank you so much.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.